Thank you guys very much for having me speak today. And I don't know, my biggest takeaway is I want to see John Scott redraw that graph he put on there from memory, and we can probably get him to do that, hopefully. My disclosures are irrelevant today. So this is the unfortunate perception of dealing with weight recurrence after gastric bypass. There's so much talked about sleeve and things like that, but bypass. So this is a quote, and I'll read it. Weight regain after Roux-en-Y gastric bypass is a nightmare for the patients and surgeons and is mostly regarded as irreversible. So I pulled this out of one of the articles I reviewed. This was their first line in their introduction, and I thought this was a very true statement, and I kind of thought I'll just do this one slide, then conclusion and done. I thought that kind of said everything, but let's take a little deeper into it. So I think the first thing we talk about that we don't really know what we talk about is how do we define quote unquote a failure? And we still don't know. So do we define it from nadir? And if you look at the data, basically everybody almost has a nadir with some weight recurrence. So is that a negative thing or is that expected? So I think how we approach somebody is very important, and we need to think about this before we start doing any revision. Is it 50% of the weight loss from their nadir, from their lowest point? Is it persistence for comorbidities? So I think how we define, an unsuccessful or less successful, I don't like to use the word failure, but how do we define this to approach, should we do revisions? When should we do revisions? What we should do for revisions? And it's a very complex process. How weight recurrence or inadequate weight loss is affected. From a general perspective, do we choose the wrong operation for that patient, or as most of our practices, the patients choose the operation? Did they choose the wrong operation? Is there a surgical complication, or did they get started on a new medication? Is there barriers to activities? The hormone. This is the more and more we talk about the medications, and our great lecture from Dr. Scott, we talk about the hormones that alter and change, behavioral factors, eating disorders, etc. There's a lot of components that go into the decision process. So when you look at more detail what the primary causes are, surgical issues, technical issues, enlarged pouch, or, made too large or has dilated but or made too large, so gastric fistula, things like that. Dietary compliance in the literature, this was the most common consideration. Why? They have dysregulated or maladaptive eating. And that's expected to be the vast majority of patients, not necessarily eating disorder, but just, significant behavioral change, along with non-compliance. Dysphagia stricture, while, I think we've all said the phrase, the patient that's coming back in with nausea, vomiting, and like, well, you're not losing weight, you're maintaining your weight, you must be eating. And that's not really the case. What happens is people would go to liquid calories, which is a far faster way to gain weight than eating actually healthy food. So these patients turn into, ice cream, regular soda. They're trying the best they can to keep things down, but they're maintaining the weight or gaining weight, but not in a healthy way. So, keep that in mind, that a complication stricture, even though they're saying the nausea, vomiting, and they're not losing weight, doesn't mean they don't have a problem. And then metabolic adaptation. And so my bias is I think this is one of the most common things. I think we all see that metabolic impact that these surgeries have on patients, that physiologic change, but our bodies adapt to that over time. And hopefully the behavioral changes maintain as our bodies adapt to it. But I think that's the biggest thing, and where there's some great opportunity for, a second hit phenomenon where you get again, another physiologic hit after revision or after adding medication, et cetera. So behavior modification, this is always our first line of attack when we have a patient with some kind of inadequate weight loss or weight recurrence. Also to it's a demonstration of compliance. I don't want to get too deep into access to care issue, but when we look at revisions, we have to fight a lot for insurance companies, and we're seeing now in the qualifications change where they're actually listing things. Dilated pouch is no longer an indication for revision surgery. The once per lifetimes we thought we gotten rid of are coming back. So we're seeing a frustration where they don't want to pay for 2 surgeries. They don't want to pay for revisions. They want to have one surgery done and be successful, and that's their shot. So we want to document that, hey, the patient's not non-compliant. So make sure you put that in your process. Make sure they don't have a dietary disorder. It's always good to, reevaluate from maybe a psychologist standpoint, and especially dietitians. And certainly what people see is their diets change. Again, I think this is that adaptation to the metabolic change. They had the initial surgery, and they start changing their diets back to increase carbohydrates, the liquid calories. But there's not a lot of randomized studies about how we approach these patients. It's just all anecdotal kind of evidence and it's kind of one-off. As is said in my first quote, this is a pretty uncommon thing. Bypass is usually pretty successful. Sadly, the thing that, kind of impacted me the most in looking at this was it's only about 6 to 8% quote, being successful with just counseling. I think we all, and I'm guilty as anyone else, we see a patient and we get, we've gotten away from the days where, your primary care doctor told you, just go diet and exercise. And we're like, well, that's ridiculous. They need surgery. Or, just do it on your own. And we don't believe that. But then when someone comes back in with weight recurrence, our first answer is, well, you just need to change your behaviors back to where they were. So it's not always successful just to go through dietary behavior modification. Medication use, I know we're going to talk about that, so I won't dwell on this. So I kind of just, pulled up one of that interesting study about the medications where the medications do help. Now, I haven't seen much on the new GLP-1, so this is older, the phentermine and derivatives of that medication, but there is impact with that, and you can see the bottom graph is the patient with medications. The patient with no medications, actually the patients that were given medications were non-compliant with it actually did the worst. So maybe there's non-compliance. Endoscopic management or revision of gastric bypass. We're having a talk on that today, so I will kind of defer to that. So going into revision surgery, which is like, basically the primary mode of what we're thinking about when we approach weight recurrence after Roux-en-Y. So the first thing that I want to, emphasize when you do revision surgery, for a lot of reasons, you need accurate descriptions of every limb. Make sure you're doing, accurate, not just eyeballing, accurate, good measurements, because you want to document what every limb is. And maintaining your total alimentary limb length must be greater than 400 centimeters and your common channel greater than 200 centimeters to avoid the severe malnutrition deficiencies. And, I would advise people to cheat a little bit more to make even longer. Don't be too aggressive, because that's where, a lot of these are case reports, things like that. The problem where people come into is that common channel length being too short, and anything under 200 is a bad idea. And honestly, 250, 300 is probably more of a consensus in the literature, more modern literature. So the first thing to talk about, and this is pretty well studied. I found some good review papers on this, looking at limb lengthening or a distalization of gastric bypass. So this is a great review of the MBS AQUIP database. They reviewed the 87,000 gastric bypass and 455 were limb lengthening procedures. The indications for this were, as you can see, primarily, as we expect, inadequate weight loss or weight recurrence. There's other reasons you can do this for, complications or other problems, but the primary reasons are for the inadequate weight loss. Looking at the outcomes of this, it was actually very positive. It was very safe. The complications were overall pretty equivalent. The reoperation rate was a little higher in the limb lengthening surgery, and that was likely due to the deep space infection or leaks that were slightly increased with revision surgery. But the thing was interesting, these were looked at as simpler surgeries. If you look at the time difference between these surgeries, the revision surgery was faster than the primary surgery, which, just doing the distal, the small bowel portion of a gastric bypass, you'd think it would be faster, and it was. So, but what this study looked at was primarily that this was a appropriate thing to do and a safe procedure with reasonable outcomes and fairly low complication rates. So I think this is a very reasonable approach. Here are the weight loss, this was a separate study looking at limb lengthening. This was the first one was the MBS AQUIP database, so it didn't have the long-term outcomes, weight loss, et cetera. So this is another really good study that had 100 patients looked at it with up to 3-year weight loss. And here's their, their index urinary gastric bypass and what it was at distalization. So again, you can see, so it was still lower, but obviously a lot of weight recurrence to get their BMI back up. And then the time frames there, where there was pretty good weight loss, and the weight loss mostly continued out and kind of flattened out at toward year 3 there was less follow-up there, but very good longer term outcomes with limb lengthening. Impact on comorbidities, they saw very good resolution rates. Again, continuing with the weight loss, continuing with the resolution rates with this procedure. So again, a very effective approach to weight recurrence and a Roux-en-Y. So, next, the next group of literature and thoughts about revising are to, traditional DS or a SADS. And, these are complex surgeries. Not a lot of literature on this, so mostly case reports. So I found, I don't have time to go through everything, but one more, this was a larger study, was 15 patients. So it was 10 SADIs and 5 BPDs, and 7 of these were staged. And so if you're not familiar with this, so you can imagine the complex approach to this. You have to reconnect the stomach to the gastric remnant, then do a sleeve, then do the duodenal dissection and that sort of thing. So this is a complex surgery. Takes a while, very challenging to do. And so the approach to many of these, and I'd say that paper was consistent with the case reports, it's about 50% or more are staged, where they just do the gastric component first, make sure there's no leak or complication with that, bring that patient back, and then do the second portion of that. So that's very common in this approach. So out of these patients, there were some significant, complications. There were 2 leaks, and so out of 15, that's not small, and 1 reoperation for significant malabsorption. Again, they got right at that 200 number in that one patient in this paper, and had to be revised at under 2 years out. So again, this was not great. The follow-up was terrible in this paper. Our insurance company was die at this follow-up, but the weight loss was pretty good. With the patients that did follow up, so they had continual weight loss even out up to 2 years. So they did have a good impact on what they did, but again, this is a complex approach. So, we hope to just generate more discussion, like what's our approach to this? It is a complex and rare thing. Is there an anatomic issue? Is there dilated pouch or a fistula or some complication? Do the patients have continued diabetes? That's a reasonable approach regardless of BMI. But is BMI alone by itself, is that enough to say, we should do a revision surgery on this patient without comorbidities or without an anatomic problem? Should we be approaching this only as, well, your BMI was 65, now it's 45, let's do another surgery? So in conclusion, this is a very complex, but thankfully pretty rare issue. But it is a revision surgery. It is safe and effective. Make sure when you're doing this that you have accurate measurement of all your lengths. And it'll be interesting to see what happens in the future. I think the newer medications are going to have a significant impact on this patient group. And I think the biggest thing to remember is, sometimes it's hard to fix a good operation. If a patient, has a reasonable sized pouch and adequate limb lengths, it's hard to make it better. So sometimes surgery, I hate to say, not always the answer to this patient population, but we needed to kind of develop a more, thoughtful approach to this, and when to do it and what to do. Great, thank you.